Treatment notes. Objective measures of language style point to clinical insights. Part 2. Linguistic measures. The linguistic measures used in the study have been described in detail in Bucci, Maskit, and Hoffman, 2012. Particularly the computerized linguistic measures of emotional engagement and effective language developed in the framework of Bucci's multiple code theory, 1997, and the referential process. These had already been applied to session transcripts. Bucci and Maskit, 2007. Table 1. Relation of clinical effectiveness and language measures for 14 cases. In brief, the stylistic features of a person's language production, how a person speaks or writes, can be differentiated using a variety of empirically derived measures. The two most central are referential activity, RA, and reflection, REF. Measures of RA assess the degree to which language is connected to the nonverbal elements of emotional processing and indicate the degree of effective connection of a language. In broad terms, high RA language is vivid, imagistic, and detailed and contains sensory information. Low RA language is abstract and general. High RA language has a quality of immediacy. It evokes vivid and specific experiences and evinces an active and direct connection between imagery and words. The Computerized Weighted Referential Activity Dictionary, WRAD, Bucci and Maskit 2006, was developed by Empiri, Cali identifying lexical items that figure in the RA ratings. In the construction of the WRAD, the importance of common func, tie-in words, articles, conjunctions, pronouns, emerged empirically. For example, words such as and, in, on, that each with weight of +1 are indicative of high RA language, in contrast to also, much, quite, whether each with weight of 0, indicative of low RA language. It is important to note that these small words are used without specific awareness of any underlying linguistic dimensions and without intent regarding lexical choice. The following examples are taken from the treatment notes used in Bucci, Maskit, and Hoffman, 2012. In the first example, which illustrates high RA language, the analyst reports a dream the patient has told. That night, she had a dream that she had walked into the luncheonette near the institute, but it was located near her work. She wanted a hot drink. She also rented a spare room in order to sleep. One of the men there asked her whether she was in Q's department or the dark room. She said she was not in the dark room. There was a girl there who serves in the cafe who said, "Why ask her who she is?" She then went to the room and heard a baby crying upstairs. In the following example, which illustrates low RA, a different analyst describes an interchange with the patient. He starts talking spontaneously about the discussion yesterday and the waving incident, how when he leaves here he has to remind himself that he is an assistant manager in order to regain his status. I recall to him his remarks about me that you would be a good analyst someday, and so forth. He then confesses that he has been thinking about his remarks about me ever since he left and wonders why he did talk that way to me. He is very confused by reality, since after all it is a fact that I am not finished with my training yet. So what's wrong with what he says, and yet he feels that there is something wrong. He goes into an obsessive rumination about what is real and about what isn't here. The differences in language style between these two passages are generally apparent to readers or listeners. The elements contributing to these differences are not so obvious. To deconstruct the application of the WRAD measure, in the first passage the 5 most frequent words are she, the, in, and room, each with a WRAD weight of 1, and the article a with a WRAD weight of 0.8125. These are the kind of words that people use when describing events or images involving other people in specific spatiotemporal settings. In the second segment, the 5 most frequent words are he, about, that, and is. Only the first of these, he, and the conjunction, and have high WRAD weights. The other 3 are weighted 0 or close to 0. Details of the WRAD list and the development of the weighting procedures are presented in Bucci and Maskit, 2006. Optimally, in treatment notes, we would expect to see language indicating engagement by the therapist with the patient and with the treatment, along with but not dominated by language indicating reflection on the material and its explication. A computerized measure of reflection has also been developed composed of words that people use to describe how they think and communicate thought. The Reflection Dictionary, REF, includes words of basic logic, such as if and but, words referring to cognitive or logical functions, such as think and believe, or referring to logical entities, such as reason and cause. The reflection measure, REF, is the average number of words matching the reflection dictionary in a text or text segment. The measures of referential activity and reflection are applied using the Discourse Attributes Analysis Program, DAP. Point 2, the main measure of referential activity used here is the mean high WRAD, MHW, the mean of referential activity when it is above the midpoint. Point 3, this measure provides a measure of the average degree of intensity of emotional engagement. Whereas MHW is interpreted as a measure of emotional engagement by the speaker or writer, reflection, REF, serves as an indicator of regulating or distancing emotional experience. By looking at the MHW/REF difference, we conjecture that high positive levels of this difference, relatively higher MHW and lower REF, indicate intense emotional engagement by the speaker or writer as the experience is described. The speaker or writer is living in the experience immediately, in the moment, and not standing back to reflect on it. The power of highly engaged narratives to express and activate emotion is widely recognized as a basis for exposure therapy, FOA, in Meadows 1997, and in psychological and neuroscience research, Damasio 2003, Ellsworth and Tong 2006, Harbour and Pennybaker 1992. Such intense engagement may be discouraged in forms of supportive treatment, in which the therapeutic goal is to modulate and downregulate the patient's affective intensity. Relatively lower MHW and higher REF indicate less emotional intensity and more emotional distance from the contents by the speaker or writer. Construct and content validation of the MHW and REF measures. Murphy, 2012-2013, has presented evidence that the WRAD measures are robust predictors of language style associated with describing vivid and emotionally significant events and have moderate to high temporal stability. The fluctuations of the MHW and REF measures and differences between them have been examined in several studies using session notes and transcripts. High levels of MHW in analyst speech were significantly correlated with clinical ratings of session effectiveness in a study of 16 psychoanalytic sessions, Bucci and Maskit 2007. In an experimental study, high levels of the reflection measure were associated, aided with judges' ratings of language segments as representing processes of distancing from immersion in emotional experience, Kingsley 2009. A high level of MHW compared to REF, high MHW/REF difference score, has been associated with uncovering phases of treatment. A low or negative difference score has been associated with containing and also in avoidant or distancing phases, both in patient speech and therapist reports, Andre et al. 2008, Crisafulli et al. 2011. Focus on the individual case, the present study. Our initial study provided a first line of evidence that the language style of treatment notes, indicating engagement of the therapist with the patient and in the treatment, can provide some indication of how well a treatment is going and is likely to go. As noted, only 3 of the 14 cases in our sample showed clear-cut improvement at the end of treatment, their current clinical evaluation, and 4 became worse, see Table 1. Table 1 shows the relation of clinical effectiveness, CCE, and language measures for the 14 cases. Cases 50T2, 60T1, and 70T3, all of which were judged successful by current criteria, with a CCE of 7 or 8, all have positive MHW/REF difference scores, whereas the others have negative MHW/REF difference scores. As noted, cases written about with greater emotional intensity by the analyst were judged more successful. For clinical purposes in supervised treatments and in all treatments, the next question we wish to address was whether these measures could be applied to the overall trajectory of individual cases that differed in outcome, to identify points in treatment where problems arose and how these might have been managed in cases that were considered effective. Method. For this purpose, we chose to examine the trajectories of 2 of our basic linguistic measures across the entire course of treatment using the treatment notes of 2 sharply contrasting cases. For one from the 1950s, 50T1, in which the patient became worse according to our measures, showing declines in both GAF and PFS aggregate scores, and ending below the clinical criteria scores. And one from the 1970s, 70T3, in which the patient became better according to all measures. Case 50T1 had a beginning GAF of 53 and a beginning average PFS of 52.6. He had an ending GAF of 45 and an ending average PFS of 48.8. Case 70T3 had a beginning GAF of 65 and a beginning average PFS of 56.4. She had an ending GAF of 80 and an ending average PFS of 78. The composite of these measures, the CCE, yielded the minimum score of 0 for 50T1 and the maximum score of 8 for 70T3. Clinical description of patient 50T1. This patient, a professional man in his mid to late 30s, was considered by experienced evaluators to be suitable for analysis and eminently analyzable. One senior interviewer who screened him said, "I would consider him an excellent and worthwhile candidate for psychoanalysis at the treatment center. It is my impression that he could effectively undertake and utilize such treatment, not only for his own benefit, but also in the service of his work." Another evaluator said, "He is an intelligent man, obviously sensitive and introspective. He speaks fluently and well. He makes excellent personal contact." The brief content given probably does not adequately convey the excellent personal impression that he has made. The intellectual qualities were mentioned before. To these may be added what seems to be a real capacity for emotional warmth. The patient's initial diagnosis was psychoneurosis. In terms of analyzability, the evaluators commented that he had an excellent prognosis. After 22 months of treatment, the patient was seen as having a severe ego disturbance that made analysis impossible. The termination summary states that he was unable to see himself as a separate object and was unable to examine himself objectively. He will require constant supportive treatment to give him some continuity with an object between visits and to preserve his facade that he is examining himself objectively. His GAF score was 53 at the start of treatment and 45 at the end. The PFS average score was 52.6 at the start and 48.8 at the end. What happened in a treatment in which the patient appeared to show such a promising prognosis at intake and then deteriorated so severely during the subsequent years? We first attempted to see if the language measures applied to the treatment notes could point to where the treatment began to show signs of being ineffective or even having a negative effect. Figure 1 shows a comparison of mean height WRAD, MHW, and reflection, REF, for the treatment as a whole, divided into natural segments covering the 2 years. In the beginning of the treatment, in the fall of 1951, the reflection line is slightly above the MHW line, yielding an MHW/REF difference score of 0.005, indicating some degree of distancing of the patient's material. The difference score diminishes during the next 2 segments, reaching 0.001 in spring of 1952. Thereafter, however, the MHW declines and the REF increases in an almost mirror image of one another, and the differences score increases and remains high during the remainder of the treatment. This reading of the graph can bring us to examine particular points in the treatment that might reveal the difficulties that emerged. Looking first at the initial session, in which the figure shows a mild distancing process, we see that the treating analyst's notes already differ from the tone of the intake. One can speculate on the reason for this. The patient is an aggressive, outspoken, neat, emphatic speaker. He begins tell ing about his potency disturbance, which has been present for the past 3 or 4 years. He has been going with a girl named G for the past 7 or 8 years. She has been chasing him and then dropped him once. The potency disturbance appeared. At this point, he breaks off and tells me he's very upset by my youth. He did not expect to see someone so young. He was prepared to see somebody who was well established and well advanced in the field and in years, who would be taking care of his problem. It is such a serious problem to him, he wants to be sure he has the best help available. Without waiting for any comments from me, he begins to wind himself up, talking more quickly and progressively louder until he is just about shouting. The content concerns my apparent lack of experience. Is the Psychoanalytic Institute any good? Is psychoanalysis any good? And so on. The notes indicate a dramatic difference between this patient's presentation to the evaluators and his presentation to the analyst. The analyst did not address the anger, either directly or possibly as in some way defensive, perhaps a more modern construction. Nor did he address the patient's concerns about his youth and inexperience and the patient's need for the best help since his problems were so serious. Throughout the analysis, from the very beginning, there were discussions about a variety of sexual issues, his potency problem, his masturbation fantasies, and dreams with a great deal of sexual content. A significant historical event that came up many times was witnessing a sexual scene when in his 20s, which both excited and frightened him. From the beginning, as in the first session and in the second session described below, the analyst seemed not to respond to the patient's communication and instead seemed to have his own agenda. In the second session, according to the analyst's notes, the patient has been thinking all about this. He did the same thing with Dr. Z and kept it up from time to time with all kinds of demands that Dr. Z answer questions that he had already answered before. However, he doesn't know what this means. He feels that only a part of it is related to what he sees as my youth. He has a disdain for younger people, and he gives the example of a little boy of 21 in a bar he was in. He was giving his opinion of the slaying of the man by 2 teenage boys who stomped him to death. The patient was completely unable to listen to the boy and felt it necessary to disregard him and to belittle what he was saying. Somehow, he feels that this kind of situation is related to the strong father who dominates him. The analyst reports that he then responded, I tell him that I would like some more data about his symptoms, and he then proceeds to tell me about the potency disturbance. In other words, the patient clearly continued to describe his angry feelings. During the first session, he expressed anger at the analyst. In the second, he described his anger toward the previous analyst and his general attitude to younger people, including the example of his feelings toward the little boy of 21. The patient makes a genetic connection to his domineering father, saying that it is almost as if he dominates younger people the way his father dominated him. The analyst changes the topic. We then come to the period in the spring of 1952, when, as seen in Figure 1, the REF and the MHW are virtually identical, indicating that the analyst is writing in a more emotionally engaged manner than in first 2 segments, fall 1951 and winter 1952. It seems possible that the treatment may take a different turn at this point. In spring 1952, it seems as if the MHW will cross over and become greater than the MR. However, the MHW declines in subsequent phases of the treatment, reaching its nadir in fall 1952 after the summer break, while the REF score increases in a mirroring pattern, indicating that the greater emotional connection that seemed in reach in spring 1952 was not achieved. We attempted to understand reasons for the precipitous drop in MHW, along with a sharp increase in REF between summer and fall 1952. To this end, we examined the clinical material beginning in the spring through the fall of 1952 to try to ascertain the nature of the analytic work reported by the analyst. Since the analyst's notes are extensive, a detailed clinical analysis is possible. It It is probably not coincidental that this nodal sequence, during spring and summer 1952, occurs as the analytic work is approaching the first summer hiatus.